Minu. Now I call upon Dr. Mathew Kurian. He will enlighten us about dysphotopsias, causes, prevention and management. Prolific surgeon and medical superintendent in Group 5.
Thank you, Sony. So what is dysphotopsia? It is basically an undesirable subjective photic phenomenon in an otherwise uncomplicated cataract surgery. So it can be positive, negative, or diffractive optic related photic phenomena. And the incidence is almost 50%. The good news is that Osher has described that the incidence initially may be higher, but generally tends to reduce over time. So if you can just buy time in most of these patients with the lubricants, etc., you will be able to be fine. And almost 750,000 people globally experience this. So what's the difference between dysphotopsia negative and positive? Positive dysphotopsia, there is a clear correlation between the optical lab and clinical findings. In negative dysphotopsia, that understanding the correlation is poorer. The positive dysphotopsia is directly related to the square edge optic design and the index of refraction of the optic material, whereas negative dysphotopsia can happen in any in the bag IOL. So if you don't place it in the bag, you have solved. IOL position is not a factor. IOL position is the key factor in negative dysphotopsia. There is only patient-related outcomes in positive dysphotopsia, whereas in negative dysphotopsia, you can actually use Goldman visual fields to measure the difference. And the CNS component, there is neuroadaptation in the negative dysphotopsia because it affects your visual fields. So for dysphotopsia related to premium IOLs, there is an advisory committee which includes members from the American Academy of Ophthalmology, the FDA, the RAND Corporation, and the University of California. And in a Mofield study, it's been shown that exchange rate because of diffractive optic dysphotopsia is about 6%, whereas in monofocal IOLs, no IOL exchange is required. In the JCRS more recent article, 64 eyes of 46 patients required IOL exchange, and this is in a period from 2007 to 2020, and 83% had diffractive optic dysphotopsia, reduced quality of vision in about 80%, and 20% had night vision difficulties. Incidentally, about 20% are post-YAG capsulotomy, and we have to learn how to manage to do the IOL exchange in a YAG capsulotomy. 20% are also post-refractive surgery cases. So the quality of vision and the impact it has can be measured by this quality of vision questionnaire, which is developed by a group from Australia. And the images are there for the patients to be able to answer that question better. And frequency, severity, and bothersomeness are graded, and a total score is given. Unfortunately, this is a paid questionnaire, so that's expensive to do it. Positive dysphotopsia is due to edge glare. Ray tracing analysis of the edge types was done by Francini, and internal reflection and index of refraction has been described by the Erie et al. In JCRS 23. Negative dysphotopsia is essentially a temporal dark arc, and this may be blocked by the negative dysphotopsia salute, the keeping your hand there, or by using a thick eyeglass frame. And symptoms become worse when the pupils are constricted and better when the pupil is dilated. This is again associated with a perfect surgery, and some of the issues that Minu is talking about, the angular kappa is possibly associated with this one. So the edge of the lens refracts some amount of light goes without refracting, and there is an illumination gap which is causing the negative dysphotopsia. And surgical outcomes, this is prevented or relieved or improved when the IOL optic edge overlies the anterior capsulotomy, so you need to do a reverse optic capture. And outcomes with the IOL exchange when it is removed from the bag and placed into the sulcus is pretty good. Piggyback IOLs also solve the problem, but if you replace a lens with another lens in the bag, you are not going to solve negative dysphotopsias. If you have negative dysphotopsia complaints in one eye, you can do a primary reverse optic capture in the second eye, and this is inevitably successful. This is a group from Rudy Nuit's group from University of Maastricht, and they have done a similar grading method to objectively evaluate negative dysphotopsia using Goldman kinetic perimetry. And they also have a questionnaire which looks at the black edge, gray crescent, black crescent, blurred edges or corners, and again scored on bothersomeness, severity, frequency, etc. So this is reverse optic capture where the lens is placed inside the bag. And it is much easier to perform optic capture, either conventional or reverse, when it is a multi-piece IOL. It's much more difficult to do this when it is a single-piece IOL, because it will usually not get maintained in that position. So here the reverse optic capture, at this stage, you are hooking the optic and prolapsing the optic into the anterior chamber, and it is hooked and maintained in that position by the rhexis margin. So consequences of this: posterior capsule opacity and iris chafing, and several anti-dysphotopic lenses are available in the market now, popular of which is the bag in the lens from Mauker. The management algorithm is, if it is persistent, you need to look at reverse optic capture, sulcus placement, piggyback IOL, or a nasal capsulectomy. If it is positive dysphotopsias which are managed by drops, then you can continue with the drops, but otherwise you need to consider doing an IOL exchange with a monofocal IOL. I'll skip this part because Mino has covered this in detail, but just remember, when you are explanting the lens, you can create a PC rent, and in that situation the pupil also can come small, and it is a good idea to use hooks, look at the area of good capsular support, and place the lens such that it remains well centered. Otherwise, Minu will come into action all over again. Thank you.
Thank you, Dr. Mathew, for that elaborate and descriptive overview about dysphotopsias. Just one question. Do you think plate haptics could have lesser amount of dysphotopsias, because the most, at least in around 180 degrees, the continuity of the optic towards the haptic continues in that?
So there are IOLs which are made which are oval optics, and those kind of oval optics reduce the incidence of negative dysphotopsia. But most of the commercially available plate haptic lenses have a central circular optic, and the rest of it is just a haptic, so they will still have some of these problems.
Okay.